Lisa Crymes, who is an innovation fellow at HITLAB and leads many of our strategy and research projects at the lab, talking to Adele Allison, who is a senior director of content and experience at CHIME, which is a network of executives in hospitals and health plans around the country. And the cornerstone for this conversation, in terms of how it ties into JP Morgan, is understanding what some of the things we heard about at JP Morgan and how it tied back to the challenges of being able to demonstrate evidence across the different regulatory and reimbursement frameworks that we're seeing develop through the pandemic now into this new era of building remote patient monitoring, telemedicine, electronic health record adoption. And again, Adele is with CHIME, which is the absolute key health information executive network in the United States. So she knows about this from the tactical levels. And again, looking forward to this interview. Lisa, the virtual podium is yours.
Awesome. Thank you so much, Stan. Adele, thank you for joining us this afternoon. We are excited to have you, and we've got so much to talk about. This is such an important topic. So let's just jump in. Do you mind sharing with the audience, a little bit about yourself and your background?
Happy to. So I've been working in healthcare for over 30 years. Yes, I color my hair. I'm an old fart. I studied systems engineering at Georgia Tech. So I'm trained on processes. Only when I was at Georgia Tech, we programmed on punch cards. So that again tells you something about my age. I have worked for both on the payer and the provider side of the equation. I actually worked for a Blues health plan, managing their provider networks and all the contracts, and real popular, set the rates of reimbursement for a Blues plan. And I actually started the first HMO in the South, which was started by UAB in Birmingham, Alabama, called Complete Health, and sold 9 years later, and is now United Healthcare. So have a payer side, and I worked 16 years for an EHR software development company as well as their National Director of Industry and Government Affairs. So sat on both sides of that fence. I like to call it the light side and the dark side, right? And depending on where you sit, it can be both. So my areas of expertise are healthcare economics, interoperability, and provider payment innovation.
I love it. Adele, I've obviously had the pleasure of working with you in the past, and I immediately thought about you for this topic because you have this amazing perspective and wealth of knowledge in these areas. So as we jump in, one of the things that we wanted to start with is can you walk us through or differentiate productivity-based versus analytical-based payments? So yeah, really getting into the fun part.
Oh yeah, let's just jump right in. So in healthcare, in our country, at the end of the day, it is all about the green on the mahogany, right? And we pay a lot of money for healthcare in this country. Third-party reimbursement was actually solidified in 1965 when the federal government got involved to provide coverage to roughly about 23% of Americans who didn't have hospital coverage. So Titles 18 and 19 were added to the Social Security Act and created the entitlements we know as Medicare and Medicaid. And with that solidification of third-party reimbursement, we were off to the races. And really that meant productivity-based payment, which is transactional. I pay when you do a service. That's basically what we're talking about. And while that particular means of payment is by no means not complex, it is very complex. It's evolved to fee schedules, relative base value units, RBRVS, fee schedules, complexity galore just in doing productivity payment. The concept as we moved into the new millennium was, let's just not purchase a service, let's purchase value. And this is something that really is moving the industry from transaction-based reimbursement into analytic-based reimbursement. So that means I'm going to define what constitutes value. And very a very real thing, a formula that they use is value is always going to be a function of measured quality and measured efficiency. And the most common measure of efficiency is total cost of care. And it's not just simply a summation of what was spent. It's also getting into operational efficiency, use of EHR, all of those things that define what happens as an episode of care. I just pulled this morning and I'm looking down at my paper, so I have this correct. So every December, CMS releases the National Healthcare Expenditure Report. So it came out last month, and it's always 2 years late. You know, they have to get their ducks in a row. But in 2021, the US spent $4.3 trillion, or almost $13,000 for every man, woman, and child in the US. That's what we spent on healthcare. And if we use the economic marker of gross domestic product in 2021, it represented 18.3% of GDP. And that's such a good measure of how much we're spending in this country on healthcare, because that means over 18 cents of every single dollar spent in this country in 2021 was spent on something healthcare related. And they are projecting that's going to grow to 6.2 trillion, or almost 20% of GDP in 5 years. So crazy how it's going on.
Wow.
So, and then when you look at our infant mortality rates and just our general mortality rates, and you compare us to other industrialized countries, we are well below the average just in those two markers. So we're just not getting the value for our buck in this country.
Yeah.
So what's happened is we saw, as we came into this new millennium, legislation and regulations galore, and it's bipartisan. We saw it in the Bush administration, we saw it in Obama, we saw it in Trump. I mean, it's not everybody agrees we need value for the dollar. They may not agree on how, but they certainly agree that we need to do this. And some of the laws that are impacting this are TRICA. Well, you've heard me say it, Lisa. I'll just
I love it.
It's my acronym. We're in the implement TRICA RPAC America Cures era. And everybody hears the bits and pieces. They don't understand how it all fits together, but it is contrived. There is an actual goal and flow of what they're trying to do from the idea of purchasing value for the healthcare dollars. And all of that requires measurement. So the name of the game is data, data, data. So,
I love it. I love it. That is, and I love that you touched on it from the different perspectives of healthcare too. So, contract versus value-based, productivity versus analytical based. So, there's a lot of different angles, but at the end, we're talking about value, and you touched on that nicely. I saw one of the comments that came up is if you get a chance, if you want to share that link, I think others we got a lot of data people around here, so I think others want to jump in. One of the other topics we talked about, and I think you can't touch on regulation these days without the topic of pricing transparency. Can you just share a couple of thoughts around that and kind of where we are? And
pricing transparency, certainly. So in 2020, and this is actually Kaiser Foundation information, if we looked at family coverage for a consumer, you were basically spending over $21,000 a year on coverage. So I worked on the health plan side. We try to tell all of our members, just what they're getting for their money. So we send them this nice little book, probably over 100 pages, of what their benefit summary is. And I see somebody's mentioning fraud, waste, and abuse. Yeah, I believe that's about a $50 billion price tag on that. But when we send this information, nobody reads it. And I would even challenge some of the people on this call today. Do you even know what is specifically covered or not covered on your health plan? So you're paying all of this money as a consumer into the industry, and you don't even know what you bought. And I can't imagine spending $21,000 on anything and not knowing what I bought. And so this is where the transparency is really starting to come in. And the regulations are really focused about engaging the consumer. So consumerism in healthcare is a whole new game for healthcare, but that's what's coming about. And there are lots of regs that are coming into play on this that are impacting providers, hospitals, health plans. It's all about releasing your data as access to the member, the patient, the consumer.
Well, and that clearly touches on, and if you want to just talk about this briefly too, patient access and patient engagement, those are topics that I love so much. But that comes into play with pricing transparency as well.
It does. And so that kind of gets into that whole idea of consumerism. So let's just kind of do some of the math on this. So let's say that I get 8 hours of sleep every single night, and I know everybody on this call gets that, right? Then that means I am awake 6,000 hours. Now I live in Alabama. I think our state motto, I've said this before, and this is no slight, is thank God for Mississippi, because we're like the dead last on health, right? I'm your typical Alabamian, overweight, and on top of that, I've got age-related problems. And when you consider around 60% of Americans have at least one chronic condition. So I'm awake 6,000 hours out of that year. Let's say I go to the doctor 4 times, and let's say that I see that doctor 15 minutes each time. That is 1 hour that doctor has to convince me I've got to manage my health. I've got to manage my care, my choices, my lifestyle. Some things we can't, like our genetics, we can't impact, but there's a lot we can. And if I'm not engaged as a patient, as an active part of that care team, that behavior, it's the biggest part of what's going to create a healthy patient. So patient engagement is a big thing, and the biggest measure of patient engagement is the patient experience. So again, I mentioned data, and data is best used when it's structured. So some of the data that is used right now to measure patient experience is known as the CAPS survey. Now there's a number of them. The steward of the CAPS survey is NCQA. And you have CAPS surveys for all kinds of things, including HCAPS is a big one, hospital survey, which has 27 measures on everything from cleanliness to proper billing, pain management, communication, and the CGCAPS, which is clinicians and groups. But on top of all of that, and that will impact how you get paid. How you score is how, we all know when we have a bad customer, they love to talk, and the ones that had a great experience never talk. So we this is a big deal. And then the other thing that's arising from that patient engagement and consumerism is more and more, almost a quarter of Americans now source their hospitals, their providers online. And there's a lot of commercial websites that are out there that have reviews, just like if you went to a restaurant or whatever. So Healthgrade, ZocDocs, Vitals, RateMD. And the biggest one that I would take a look at if I were a provider, a hospital, a doctor, even a health plan, is the Compare websites. That is using empirical data off of claims, which is our most pervasive data, and the CAPS surveys to actually allow consumers to compare up to 3 different entities. So 3 different hospitals, 3 different providers, to see what kind of experience they give, so you can make an informed decision.
That's awesome. I mean, and of course, all of this, certainly again ties in together. Well, Adele, I knew we would run out of time. There is so much to talk about. I hope you come back and join us again. It looks like the audience definitely loved you and had some great feedback along the way. So great to see you, and look forward to next time.
Of course. Thank you so much.
Thank you.
And thank you, Lisa and Adele. A great conversation about what is going on the front lines of digital health, particularly coming off of JP Morgan week. Thank you both.
You're welcome.